So the objectives that I'd like to cover today is first, appreciate how women are different from men in sexual response, learn the anatomy of the pelvic floor and sexual structures, discuss how pelvic floor dysfunction can contribute to sexual dysfunction, and understand the role of pelvic floor PT in treating sexual dysfunction. So you may have heard it said that men are like a microwave. So arousal within seconds, and ding, the light or the beep goes off and they're ready to go. On the other hand, women are like a crock pot. It takes a little bit of while to get things brewing, right? Say it can take up to 20 minutes before we get aroused. Okay, so this is a couple different paradigms. So the old paradigm, this is Masters and Johnson's, I think that's what it is, but it's the old paradigm is right here, and it's like you have this libido and arousal, and then once it gets to the top, it's climax, orgasm, and then boom, resolution. Well, now the new paradigm for women is intimacy, needs, sexual responsiveness, a sense of intimacy, love, affection, and then satisfaction, and that satisfaction might not be orgasm. So what hormone is the love hormone? Quick, before you read it.
Oxytocin.
Oxytocin, exactly. So that is the hormone that is released in women most, and it is called the love hormone. And it is shown that when a woman is in love with her partner, the stronger her orgasms are. Oxytocin, the love hormone, is involved in all kinds of intimacy. It's secreted up to 5 times its normal concentration with orgasm. It is released with hugging, snuggling, and breastfeeding. It's even found in semen. So oxytocin is the most important part in a relationship and sex. So looking at our pelvic girdle, and I'm going to get my little pelvis here. So we're going to look at it from first starting really superficially. We're going to look at the vulval first before we even look at these pelvic floor muscles. So we're going to learn about the anatomy of the clitoris, why it's important, Gspot, so forth, okay? So first we're going to go bony pelvis, which is here, and then the vulval, and I'll show it on another slide, the pelvic organs that are nestled deep within this little pelvis here, the pelvic floor ligaments and the pelvic floor muscles. There's lots of stuff, just like Dr. Casperson said, nestled in this little region here. So, external appearance, this is a vulval region. So on the top, we can orient, the mons is on top and the anus is over here on the bottom. And labia majora, the minora, urethra, clitoris, and the vaginal opening. So what's important is that most of us know that the clitoris, and there's that little knob that we know that we can touch externally, but there's also these parts of the clitoris that actually span out like butterfly wings, and they're hidden deep within the vulval region. A little bit more of a detail, but these areas are like little wings or little appendages that are deep within, and every woman's position of those are different sensitivity, configured differently, but the clitoris has the sensitivity 8,000 times, and they say at least 5 times more than what a man's penis is. So super duper sensitive, the function of the clitoris. It's only found in human females. The sole purpose is for sexual function. During sexual arousal and during orgasm, the clitoris and the whole of the genitalia engorge and change color as these erectile tissues fill with blood. During orgasm, the women can experience vaginal, uterine, and pelvic floor contractions, and the majority of women require stimulation of the clitoris in order to experience orgasm. So that G-spot, we've all heard about it, but what is it? So the G-spot is said to be part of the clitoris and those appendages, and there's like a little meeting spot. Now, some women have a G-spot, other women don't know if they do or they don't even have one. It's all, again, the configuration of the clitoris and those appendages called the crura. So Dr. Helen O'Connell, using an MRI, noted a direct relationship between the legs or roots of the clitoris and the erectile tissue of the clitoral bulbs and corpora, and the distal urethra and vagina. She asserts that this interconnected relationship is the physiological explanation for the conjectured G-spot and experience of vaginal orgasm, taking into account the stimulation of the internal parts of the clitoris during vaginal penetration. So here's another spot. So there's the G-spot. If you can envision, here's the bladder, here's the uterus, here's the vaginal canal. So it's really pretty close to the outside area. So anatomical changes with arousal. We have those neurotransmitters and that oxytocin that cause vasodilation and increased blood flow to the genitals. Vasocongestion occurs in the pelvis and breast. Vaginal lubricates, or the vagina lubricates, lengthens and dilates. The uterus rises over the levator plate, and I'll show you, next slide will be able to show us that. The other third of the vagina tightens and narrows, and then with clitoral stimulation, the clitoris engorges with blood and lengthens and widens. So here's a slide. This is a woman in an MRI machine, and she is masturbating, and it shows what is happening at baseline, at orgasm, and 20 minutes post-orgasm. So I'm going to use my finger to point here. So look at the relationship with vaginal canal, here's the uterus, and see how it lengthens a little bit and the uterus lifts up? And then over here at climax, vaginal canal, see how much higher it is? But what else do you notice in this slide? Her bladder's full. Can you tell? So, what is that? When there is that lack of arousal because of pain, then those physiological changes, they don't occur. Those anatomical changes don't occur. So what can happen if the woman's like, okay, I'm just going to be nice tonight and get this over with, then there can be this condition or situation. It's called collision dyspareunia. Dyspareunia means painful intercourse, or bumper dyspareunia. And what that means is that there's not enough room. And what happens is that that penis can hit the cervix or other surrounding tissues around there. And so it hurts because it happens over a repetitive amount of time, right? So it's important, as I coach my clients, is that arousal is important. There needs to be that foreplay, there needs to be that ramping up time, because there is these changes that happen in our body. So it's another way of just trying to avoid pain by education. Kegels and orgasm. The pubococcygeal strength was not found to be positively related to frequency or self-reported intensity of orgasm. Women with higher pubococcygeal strength did not report more pleasure or more orgasms. The coccygeus is a muscle in our pelvic floor. However, women who were treated for prolapse, incontinence, or pain did report improved sexual satisfaction after treatment. Yet, I think that we do coach that if you are active sexually and you have orgasms, is that not a great way to strengthen your pelvic floor muscles, because it's a spasm and a contraction of that muscle. So, it's all about balance. When we're looking at the pelvis and the pelvic floor and that whole region, it's all about mobility and stability. Diane Lee is a rock star in the physical therapy pelvic health world. And what she says is the goal of restoring motor control for low back and the pelvis is to ensure movement patterns that optimize function of the joints and organs. The result is stability with mobility, fluidity of movement without pressure on the pelvic organs. And I love this slide because it's divided between superficial and deep pelvic floor muscles. And what's to appreciate in this slide is there's a bunch of them. We have a lot of muscles and we think it's just a Kegel muscle and there's just one of them. But there's actually, we have superficial, we have layers, and a different second layer is what we call it, around the urethra, as well as a deeper layer. And this is where, like Dr. Casperson said, when those babies are, when there's childbirth and it's a natural childbirth or vaginal birth, the impact on those muscles. We know that the purpose of, and this is a common one, the purpose of our pelvic floor muscles, we know, is to provide bladder control, to provide bowel control as well. pelvic organ support, supports our spine and our pelvis, but another real important role of our pelvic floor muscles, if they're healthy, is sexual function. So the role of our pelvic floor muscles during arousal. During arousal, those superficial layers help to engorge the clitoris with blood and fluids and maintain clitoral erection. And the deeper layers during orgasms, they contract approximately 8 to 12 times, lasting 4 to about 10 seconds, followed by vaginal and uterine muscles. So pain and arousal. What happens when there's pain? The anticipation of pain inhibits arousal, and anatomical changes do not occur. So even if a woman even thinks that this sexual experience is going to be painful, that button, that volume turns completely off. So if orgasm does not occur, but there's just a little bit of arousal and a little bit of excitement, but then there's that, oh, this is going to hurt, put the brakes on, the consequence can be cramping, congestion, heaviness, or pain in her pelvic region. So she already has pain, or thought she had pain, and then she gets to this bit of arousal, but then she thinks the pain, and then doesn't have the intercourse, and guess what? She gets pain. So what happens when our pelvic floor is not balanced? So when we think of our pelvic floor, we want it to be a balance, just like Diane Lee said. Balance is everything. So when it's normal, our pelvic floor, we have that ability to contract it or activate it. We have that ability to relax it, and we have that ability to be able to bulge the pelvic floor in order to evacuate. But sometimes our pelvic floor can be underactive, and maybe that's after having a baby, or what have you, a surgery perhaps. So some things that happen when it's underactive is leakage, pelvic organ prolapse, voiding dysfunction, back and SI pain, or postpartum pain. But then there's this pendulum that swings that you can have overactive pelvic floor muscles. And with that, it can be bladder emptying can be difficult, bowel evacuation can be difficult, painful vaginal penetration, back pain, pelvic pain, icy bladder or painful bladder syndrome, vulvodynia or vestibulodynia. Those are different conditions that involve the vulval region, and pudendal nerve entrapment and neuralgia. So looking at with the pelvic pain, it can be a mystery. And pelvic pain can be defined by, and it's common that it's sometimes named after the organ that hurts. So if my vulval region hurts, I got vulvodynia. If a man has prostatitis, he has chronic prostatitis, or maybe pudendal neuralgia. Or perhaps because I have IBS, well, I have a colon issue. So it's typically because we don't really know, it's hard to name it. So it's not like we're coming in with, doctor, my thumb hurts, and you can show the doctor this is where it hurts and this is where it's bruised. But with pelvic pain and pelvic issues, it's sometimes tough to figure out what exactly is driving that pain. So pelvic pain can be derived from all different parts of the pelvis, intestines, bladder, back, abdomen, thigh, groin, and more. There are other different causes of pelvic pain too. This would be what Kara might see. Stress, anxiety, change in relationships, financial stressors, all of those type of things can feed into the pelvic pain issues. Hormonal changes, scar tissue, medications. So pelvic pain impact on sexual function. If you have someone that's coming in with pelvic pain, their arousal isn't there, they don't have the sensitivity. A lot will say, I just don't feel anything when I touch my clitoris. Penetration is painful. Pelvic movement and positioning is difficult. I can't move my pelvis. I have to have all these pillows. Every time I try to move it in a motion, it kills me. One of the handouts that I have here, which is interesting, anybody can take, but it's orthopedic considerations for sexual positioning. So we commonly give this handout to our clients, and it has front and back, and it's great because it has all different position, and it has a key to if there's a situation, be it pain, be it hip pain, be it prolapse, then it suggests different positions that might be better or might not work. So I want to just talk briefly, because this is a huge topic. It's called the neuroscience of pain, and in this one specifically we'll talk about pelvic pain. So what does this mean? It is a study of how our brain reacts to pain. And here's my situation. Here's a woman that comes in and she says, why do I have so much pain after my surgery? And my friend who had the same exact surgery has none. There's this alarm system that our body has, and it's this connection to our nerves and how it goes and signals up to our brain. So if we step on a nail, it's immediately going to tell us, oh my gosh, I stepped on a nail, the signal goes to the brain says, ah, it hurts, I have pain, I'm going to move away. Oh, it doesn't hurt anymore, and my pain threshold goes back down. But sometimes in individuals, there can be, and sometimes there doesn't have to be an injury. It could be a surgery, an injury, and sometimes there's nothing at all. But the alarm gets ringing really loud, and the brain perceives this message, and what happens is that it doesn't come back down. It doesn't come back down into this normal threshold that we live with on a normal basis. So these nerves are always on overdrive. They're always really active. And so throwing in different kinds of stressors, be it work, be it relationship, be it finance, what have you, feeds into this. And it just keeps that threshold higher than it would be otherwise. So in pelvic pain with our women, one consequence is painful intercourse. The other, though, is that taboo. It's easy for me to go in and, doctor, my thumb hurts, but it's not easy to go, Angie, my vagina really hurts today. We don't say that. We don't even know where it is and any of that, and we're not going to go, hey, Bob, my vagina hurts, but let's go have a beer after work. You know, we just don't say that. So it becomes this taboo, and we get worried about it and kind of blow it off, and we don't talk to the doctors. So it just kind of fills in on that whole stress kind of reaction. So then on the next slide, so one of the analogies, and it's a great book, it's on pelvic pain, and it's on this little table here. And the author, Adrian Lowe, and he also has other colleagues that's contributed to this book, but his analogy is this measuring cup. So I brought water and stuff, but I probably won't pour it in to make a mess. But basically it is, you have this measuring cup, and this is, and I've been explaining this to my patients, like, you know what, 1/4 of a cup is perfect. This is where we need to live, and this is normal. But when we start putting things into this measuring cup and we're pouring it, and it's getting fuller and fuller, and all of a sudden it starts to overflow, then those signals go to our brain and it sets off that pain perception. Versus if it's just low. So the goal is how do you keep things from pouring into this, and how do you keep it from not overflowing? So lots of different reasons why this cup might overflow. We've talked about a lot of those already. But basically that brain receives the message that if it's overflowing, it has to protect. And so what's it going to do? I have pain. Even thinking about pain can cause pain. So as long as this measuring cup does not overflow, really all is well. So here's super PT woman. PT's role in managing sexual dysfunction. I thought it was kind of Wonder Woman, and I was going to put, that could be a female woman, that we're here, we're strong. Could be me as a PT practitioner, or it could be, this is kind of a demonstration on our muscles, and our muscles are trying to do everything they can to work and fight and support and relax when they need to, and you have all of these things coming at them. What do we do as physical therapists when we have a client that comes in? First thing is, and I think the biggest thing is, when I have clients that come in, they might have a difficult time explaining what's going on. This is difficult. I haven't talked to anybody about this for years. I finally went to my doctor and she said I need to go to physical therapy. So then they come in with their gym bag and tennis runners. And then it's sitting down and it's explaining. And there's a lot of initial patient education on what we do, what our role is to help them. Yes, it would be great if the first exam we could do that pelvic floor assessment so we could assess all the muscles and tone going on in this pelvic floor? Can we appreciate and reproduce some of their symptoms? We're looking for the driver. But it might be that, you know what, that woman is, I just don't feel comfortable doing this today. That's fine, we're okay with that. The doctor's already done all that stuff to rule out anything that might be a significant medical issue. So it can be that we'll look at posture, we'll look at breathing, we'll look at how the spine, hips, and pelvis move. We'll look and see how strong they are, if they have good sensation, how they're walking. Look at their abdominal function. Do they have a diastasis or a little separation in their abdomen? We might say, you know what, can I just put my hands on your tummy? How do you feel with that? We might start externally and look at the external perineum and those superficial pelvic floor muscles. If we do an inner pelvic exam, then we are looking to see, can that person contract? Can they relax? Can they bulge those pelvic floor muscles? And we're really, with a very gentle touch, looking for tone trigger points, which are little hot spots in those muscles. And trying to, hopefully that we can find, and not so much diagnose, but certainly validate why the woman is having these issues. And it's usually pretty straightforward, even them coming in with their history, because if you've done these for a while, you can pretty much put those pieces together. So really our intervention and what we want to accomplish, our goal is to keep that measuring cup empty or prevent it from flowing over. We want to work with a team of caregivers. We want to establish with our women, our clients, that you're in control. Again, sex should be pleasurable, it shouldn't be painful. You know, it's kind of this mantra that, at least how I practice, I don't want to cause pain. You're already coming in with pain. So that's kind of this negotiation that I have with my clients, is that I don't want you to leave feeling terrible. I want you to leave feeling like, yoo-hoo, something can be done. This is a good thing. So the importance of addressing pelvic floor dysfunction is equally as important as calming down the nervous system in order for treatment to be successful. So some of the things that we do in physical therapy, patient education is a big one. Explaining what we're doing and why we're doing it. Down training. Down training is a technique, and there's lots of different ways to do it. Basically, it's trying to take the autonomic nervous system and calming everything down. It's relaxation. It's mindfulness. Biofeedback, manual therapy, and I have some props so you can see what those are. Tools for self-treatment. We do a lot of posture education, making sure that the pelvis is symmetrical and it's moving appropriately. Looking at seating devices, cushions, stability belts, and aerobic and other exercises. So on the next slide, I think it has a slide of biofeedback, and it looks like a graph. So I use biofeedback a lot, because if we have a client that is not able to tolerate any type of internal work, this is a great place to start, because then they are learning how to control and manage their pelvic floor tension. And successful homework, and this is common, is getting a client in that said, I use the dilators, they hurt, and I'm not going to use them anymore. And my thoughts with that, and I'm sure Angie can attest to that, is that the education, the down training, the relaxation, the gentle massage, all of those in addition to using the dilators is usually a more of a successful outcome. Other one on the next slide is the picture of the TheraOne that's very similar. But with this, it can be used not only for doing a little dilation massage, but it also can be used for trigger points. And trigger points, again, are those little hot spots that can happen in the muscle. And if a muscle is holding over time, overactive, and it's really tight, then the consequence is trigger points. So conclusion, women are complicated. Understanding of a woman's sexual anatomy and physiology continues to evolve. Sexual pleasure and orgasm for women is a holistic mind-body experience. Pelvic floor dysfunction can negatively affect sexual enjoyment, and pelvic floor PTs can help sexual function by reducing leakage, prolapse, and decreasing pain.